Good evening. Good evening, dear all. As you know that we are going to start a lecture of WebSankul. So this is a WebSankul Alpha Batch demo lecture. Today I am going to talk about the PFD subject. So this is me, Joyal Tejpal. I have done my masters in neurology and neurological conditions. Have experience of more than 8 years. This is our team which is working for this WebSankul, and so-called we are waiting for this physiotherapy vacancy since long, and we are going to focus on this particular lectures. So how we are going to work with? So we are going to start with physical and functional diagnosis. I'm basically going to take about physical and functional diagnosis syllabus or subject of that, as physical and functional diagnosis is a very important and basic subject of our PFD, of our physiotherapy, as we are going to learn about all the assessment points in that. So we can be very clear about how the patient needs to be assessed or what are the things needs to be done. Hello, hi. So this is a basic syllabus of it. As you can see, the whole exam syllabus is obviously vast, as it will be including from first year till final years we'll be having. So specifically, if I'm talk about the physical and functional diagnosis, so we have a neuromusculoskeletal dysfunction such as pain, altered muscle power, mobility, endurance, limb length, posture, gait, hand function, starting from head to toe. We have all the things which will be included in our assessment portion. Then we have physiological and biomechanical basis of movement dysfunction. Then we'll be having a physiology of nerve impulses. Specifically, then we have a electrodiagnosis, which is a major important portion of the PFD, that will be including our strength duration curve. We can also learn about the nerve physiology, nerve muscle physiology also, that has been taken lecture just a day before. So you had learned about the nerve muscle physiology in that as well. So after that, we are going to start with strength duration curve, that how it is going to be work or what are the things that we can assess into that. Then we are going to start with the EMG NCV, what are the biofeedbacks that will be helpful. Then we are going to see about the principles of nerve conduction, F wave, H reflex, how this is going to be work into that. Then comes with all the EMG parameters, biofeedback. Not only the neurological portion, as PFD includes our cardio and orthopedics as well. So whatever important points which will be there in ortho as well as in a cardio, that will be also included. That is assessment of orthopedic dysfunction, assessment of neuromuscular dysfunction. This is a very short terminology which has been written, but definitely it's a very long topic, or the assessment portions are there. Then we are having the assessment of the cardiopulmonary dysfunction, starting from the auscultation, the demographic data, and what are the other important aspects which we can cover. Then we will having interpretation of the various investigations. Radiological investigations are also there. What are the EBG analysis, what are the blood analysis, CSF analysis. We are going to revise, we are going to see the MCQs of that as well. And then we can go about this PFT analysis, assessment of the pain, assessment of the hand, as well as the sports effect as well. So before starting from the PFD subject, I am going to start with the neurology assessment first. I am going to cover a basic neurological assessment. I am not telling that all the things or all the questions will be related to this assessment, but this is a general very brief we are going to start with, that is a neurological assessment. And then I will be covering with the higher mental functions, cranial nerves. We will be also discussing that which particular questions could be asked, how the questions can be formed, which are the difficult levels of the questions would be. So we can see all these things in that. So first is demographic data. As we all know, we are starting with all the demographic data, starting with the name, that to build a rapport with the patient. As I can see your names also on the chat, that someone is telling the hi and other messages. So hello everyone, we are going to start it with it. Then we are going to for the age. Age is very important to specifically know about the age related disorders, whether it is in neurological, whether it is in orthopedic, whether it is in cardiology. So there will be chances, like if it is a osteoarthritis, so we know that once the age is advancing, there will be degenerative changes that is going to be started. So that would be present. If we talk about neurological conditions, so there are some conditions which are there common in the adult cases, and some of the cases or some of the diseases are more common in our pediatric conditions. Then we have a gender. Many of those diseases are more specifically in a male gender. Some of the diseases are very common in the female. So if it is a gender specific disorder, then also we need to know that what exactly it is. Then we are going to check about the occupation, as this is a very, very important thing. Occupation is important not only to know that how the injury has been occurred, even it is very important to know that how the patient will require the recovery. Like if the patient is writer or if the patient is computer operator and patient is having stroke, the right sided of the body has been affected. So there is major changes in his or her life that he is not able to do some work. So for that also we need to know that how the occupational changes are there. Then we are having a dominance. This is most important. This is most important, that is we need to know about the right sided or left sided. This is more important in neurological cases, as for example majority of we are right handed. Some of the people are left handed also because of dominance hemisphere of our brain. If my left hemisphere is dominant, so that is more I am a right handed people. So the same, like if patient is having a right hemiplegia and patient is right handed, so there is major difficulty in his ADL life, that is daily activity. In that there will be a major difficulties would be present. So for that we need to know the dominance as well. Then address, to know the repo or to know how the patient is traveling, how the patient is commuting, how they are going with it. Then we are going to see about the date of admission, so that we can get to know that when the patient has been admitted, patient कब admit हुआ और patient का क्या diagnosis है, what is the prognosis of that, how the progression has been occurred. All these things we can get to know through the date of admission. Date of assessment, like we had assessed on the day of start when the patient came or after certain days. So we need to know all these things. If the patient has been gone for the surgery also, so we need to know that whether the operation has been done or not. So these are the particular demographic details that we need to know. Then we can go with the duration of condition. Specifically, if I talk about not only neuro but in all the conditions, we need to know that where the exactly onset has been occurred. Like if patient is having a road traffic accident, patient is having fracture or patient is having a stroke, we need to know that from where the symptoms has been started. It is just a day before, it is 1 month back, it is 1 year back. So according to that we can get to know that how the prognosis needs to be gone. Then we can go for the progression, whether it is a intermittent, whether it is continuous, whether it has been improved. Sometimes it happens that patient condition is gradually improved. Sometimes it happens, many of the, if I talk about neurological conditions, like one of the conditions that is multiple sclerosis. We can, just a second if you are not able to hear the voice. So we are going to, okay fine, we'll just check whether you will be able to hear the voice or not. We'll make sure of that. So we are going to also check about the duration, and we are also going to check about the progression, that how the patient is going on. Like if I talk about the multiple sclerosis, so there are lot many systems which is included in that, and multiple sclerosis is also one of the condition in which there are episodes of symptoms would be there. Like one time it happens that patient has so many symptoms would be there. After that the patient will be having a subside phase would be there, and then after 1 or 2 years patient will be having a sudden symptoms. So we need to know whether there will be any rest period would be there, or whether the symptoms are gradually increasing, or whether there will be any break which is coming in between or not. Then we can go for the spontaneously reported, whether if many a time it happens that patient comes to us after 2-3 days. Like once, for example, if I talk about any kind of infection or any kind of fever, usually what people do, they'll ignore for 1 or 2 days, like this is a common fever, and then gradually we get to know that this is something very serious which is affecting the brain. So how the exactly it has been reported to the hospital or to the emergency medicine, that is also important. So we can get to know whether the prognosis will be better or not. This is, as I talked about the left side and right side of dominance. We'll go in a detail of this when we talk about the higher mental functions, specifically perception and the other things. Then we go for the chief complaint. This is also important. It needs to be always in patient's own words. It could not be in a medical terms, like it can be in a difficulty in chewing, difficulty in standing, difficulty in sit to stand, lot many things. And the most important thing, since when the patient has been started all these complaints. So these are the most important things that we need to write in a chief complaint. Chief complaint could be definitely different in ortho, neuro as well as in cardio. Then we talk about the history. So how the history of present illness would be. So we are starting with the what are the symptoms that patient has, whether the patient was conscious, whether it was trauma, whether it was a gradual onset would be there, whether patient is having a tingling numbness has been started, whether patient is having just unconsciousness and patient is not able to lift the arm and limb, whether patient is having a secretions present, that is a lot of cough would be present. So which are the chief complaints or what are the complaints that patient had of his condition, that are the things we need to ask in the history. Past history is also important to relate something which has been already done to the patient. For example, if patient is having a tuberculosis in a past history and now the patient is having another pulmonary condition, so we can easily correlate that the lungs are already weak and now due to that also we need to more focus on to the lungs, or we need to more focus on the ventilation or the other things. The same way, if patient is having a history of stroke, so in that also we need to know that whether what are the symptoms that patient had initially and now due to the previous stroke patient is not able to lift the hand, or due to the recent condition patient is having a issue. So we need to know all these things in a past history. That is useful to consider our diagnosis. Like we can take examples of TIA, that is transient ischemic attack, previous history of stroke or hypertension or any peripheral neuropathy or diabetes has been done. Then comes with family history, that is similar conditions like among the relatives or Huntington's disease. Huntington disease is a genetic disease which patient would be having. If patient is having a genetically some of the disease, that can be inherited into the genes or into the family members. So we need to ask about those particular history as well. Medical history, whether the patient is suffering from diabetes, hypertension, whether any other related condition, because if patient is on some of the medication, this medication also hamper patient's treatment or that can hamper the patient prognosis as well. So we need to ask what kind of drugs patient is taking, or due to that particular thing. For example, if I talk about diabetes, so might patient will be having a more fatigue would be present, might be patient is a chronic diabetes, so there will be chances that patient sensory issues could be also there. So we need to know that what are the other relevant things which is present into the patients. Past and present drug history, as I told you, whichever drugs has been taken by the patient, we need to know specifically. If I talk about any of the medicines that causing a giddiness to the patient, and we are going to start with the balanced treatment. So we need to know from where the patient has been started a treatment or from where the patient has been taking a drug. So we can get to know that this is the perfect time to go for a gait or balance training, or we can advise patient to do some of the things. If I talk about if patient has been given mucolytics or other drugs, and then after we are going a chest physiotherapy, so that will be more helpful for the patient to remove the secretion or to loosen out the secretions. So we need to know what are the past medications patient has been taken and what are the present drug history would be there. Past and present surgical history, that is also important as we can relate with the recent condition of the patient. So we need to know about it. Personal history as smoking, alcohol, some of the drugs or any specific food habits, and sleep. This is most important things because these are the particular things or substances if we are taking on a regularly, if we are taking on a regularly basis, then we can get to know that how much it will be affecting our brain, our lobes, our lungs, or what are the effects of that. So whenever we are asking the patient, we need to ask that how many cigarettes per day, how many cigarettes, and according to that we can count a pack year. So we can consider that how the patient's affection which occurs within the lungs or within the brain. Psychological status, this is most important as we are going to deal with a patient for a longer period of time. So we need to know that whether the patient is able to cooperate, whether the patient is depressed, patient is required emotional support, or how we can talk with the patient, or how the comfort zone of the patient would be coming, so the patient will be getting a more recovery and more better prognosis. Socioeconomic status, as it is a most important, because patient has to come to us, patient has to travel, patient has to commute. If patient is earning itself, he or she has to take care of the family as well. So whether the patient's socio-economic background is good, whether they can afford the treatment, whether they can bear all the things which has been happening, so that is more better to know. Differential diagnosis. So this differential diagnosis also we can consider with the help of the history and other observational points. So I hope you all are clear with this. This is a very basic demographic data that is most important whenever we are starting with the assessment. These are the commonest points, whether we are taking a case of neuro, whether we are taking a case of ortho, or whether we are taking a case of cardio. So now we can get to know that if a 52-year-old male present with a dizziness, blurred vision, past history of TIA, that is transient ischemic attack, which part of the history is most important for diagnostic correlation? So, the first is personal history, second is family history, third is past medical history, and next is socio-economic history. I had already mentioned the answer, but I want to know from you that which are the particular answer which is more related. The answer is past medical history, because patient is having a history of TIA. And again, the patient is having a dizziness along with the blurry vision. So that can be also one of the reason that patient's affection in the brain could be occur, and we can correlate easily. So this is the most important history, that is we need to correlate with the past medical history. Now these are the general signs or general vitals that we have to take: the temperature, we have to check pulse, blood pressure, respiratory rate. Fifth sign, that is we need to check the pupil size as well. Pupil size is most important in neurological condition. If it is unequal, that also creating a major sign to the doctors as well. If it is not normal, if it is abnormal, or whether any other discomfort would be occurring. Pain assessment, we are going to take more in a detail when we are talk about the orthopedic assessment or some special test for that. That includes site, on-site site, that means where particularly exactly the injury has been done. If the fracture has been done, so where the fracture has been done, what is the site of that. Then we can talk about the onset, whether it is sudden, whether it is gradual. Sudden, like if we are having a road traffic accident, so we can get it sudden. If it is gradual, like patient is having a fever since 2-3 days, and then suddenly patient is having some of the symptoms which will be gradually started. Insidious, like any of the things has been happened. Duration, whether it is acute, subacute, or chronic. Acute, that is it is occurring within a 24 to 48 hours till 7 days. If patient is having a symptoms of that, we can consider acute. Then after till 1 month, we can consider 1 to 3 months, which will be subacute, and after that it will be considered as a chronic. So we need to know about the duration. Then what are the aggravating factors and relieving factors? Like sometimes it happens, specifically if I talk about the ortho, like if patient is having a back pain, so some of the things which will be there, like if patient is telling us that if I am doing a long time or prolonged standing, or if I am doing sit to stand, so there is major chances that patient would be having a pain. So that could be possible, that is aggravating factors. Relieving factors, like some will be feeling a more good, like when they do a flexion or when they do a extension. So some of are the relieving factors, some of would be having a rest, drugs, any physiotherapy medications, or any physiotherapy treatment, or any of the medication. So that can be also play as a relieving factor. Then we need to know the intensity of pain. Two major important scales that we are taking for the pain, that is our NPRS, Neurological Pain Rating Scale, and VAS, that is Visual Analog Scale, which we can give to the patient, and we can get to know that how much they can score the pain. Severity of that, whether it is mild, whether it is moderate, whether it is severe. Definitely, if we ask anyone that how much pain is there, they are going to tell, हाँ बहुत ज़्यादा pain होता है. But still, we need to know that whether it is mild, moderate, severe, because whenever we are getting to know that whether patient has been improved or not, pain has been subsided or not, for all these things we need a proper documentation, proper report, so we can get to know whether the patients are fine or not. Behavior of the pain, whether it is local or radiating. Sometimes it happens that patient will complain के यहाँ पे दुखता है एंड धीरे धीरे ग्रेजुअली स्टार्ट होता है, जो हाथ तक जाता है, टिंगलिंग होती है या झंझनाटी जैसा होता है. सो दैट काइंड ऑफ थिंग, whether it's a local pain or whether it is a radiating pain, that also we need to ask. So these are the different type of pain. This is in a brief. We are going to learn a detail in that when we talk about more of pain assessment. As I told you, when we talk about the special test or in pain, we will talk about this. But for example, if patient is having a muscle involvement would be there. This is a structures which is involved and this is a type of pain which is involved. So if the muscles are involved, like if muscle injury has been done or if any muscular pathology which has been included, so patient might be having a cramping kind of pain. Majority of people will be having a calf pain hota hai. Fine, so that cramps could be there or dull aching pain would be present. If the nerve root compression is there, specifically occurs due to the age related changes, so patient would be having a sharp shooting kind of pain because the nerve is getting compressed and due to that it is complete sharp shooting kind of pain would be present. Then if the nerve are involved, that will be also sharp, bright, lightening, like continuous tingling kind of thing would be present. Sympathetic nerve would be involved, so there will be more burning kind of pain would be there, which is present in many of the condition. Patient बोलेगा कि हाँ बहुत जलन होती है. Fine, so those kind of burning pain would be there. If bone is involved, that is a very deep nagging and dull kind of, which happens in cases of fracture. Like when the fracture has been occurred, that is a tremendous pain which will be there. If fracture, that is a very sharp, severe and intolerable pain would be present. And if it is a vascular, so there will be chances it will be throbbing kind of pain. Throbbing kind of pain and diffuse pain would be present. So these are the things which we need to take in a pain assessment. Then we are going to start with on observation. This is very brief on observation, like we need to know about the body weight, whether it is mesomorphic, whether it is ectomorphic or endomorphic, and attitude of limbs. Specifically, if I talk about the neurological condition, so patient will be having some of the postures would be there, like their hand would be this particular position would be maintained. So what kind of attitude of limb patient is having, that we need to mention, specifically of upper limb and lower limb, like it is internally rotated, plantar flexed are there. So we need to write about the lower limb. Sorry. Posture, very important. You are going to learn in a different details as well, but how the postures of the patient would be, whether it is in standing, whether it is sitting, and whether it's a supine position. Like if we talk about a Parkinson's patient, so Parkinson patient would be having a phantom pillow posture, like their already posture will be stoop and it will be seems as a pillow which will be capped. If the patient is in still supine position, we can get to know that the pillow is there, but actually pillow is not there, but still the patient is having a cervical flexion, that's why it is looking like that. So that is called as a phantom pillow posture. Some of will be having a very flat back, some will be having a increased lordosis, some will be having a scoliosis. That congenital deformity can lead to the gait disturbances and many other things. So alignment is very important to know that how the patient posture is. If we can correct, even we will be having, like if we are not sitting properly, we'll be having also shoulder pain, back pain would be present. So we need to know how the patient will be having a problem. Then gait, that is more important. Like if we talk about a different condition, patient is having a different type of gait pattern would be there. If I talk about cerebral palsy, depending on the type of cerebral palsy, either they could be having a seizuring gait pattern, either they could be having a more toe walking gait could be there. If I talk about hemiplegic gait, they'll be having a circumductory gait pattern would be there. If I talk about Parkinson's, they'll be having a shuffling gait that is very fast. They'll be walking with a very, very narrow and very fast steps. That is a short shuffling gait or fascinating gait. If patient is having pain, like lower limb fracture has been there or any of the injury which has been occurred, so patient will be walking with pain. That is called as an antalgic gait. So there are different gait patterns are there. External appliances, like patient is walking without any external appliances, any IV cannula has been done in the patient is walking with the stick, whether patient is walking with the walker, whether patient is having a tripod or any other things are there. Mode of ventilation, if patient is needing that. Type of respiration and pattern of respiration. This is most important in neurological condition, as respiratory is also somewhat, depending on condition, definitely somewhat also subsided. So we need to know whether the patient respiration is proper or not, whether it's a normal abdominothoracic, thoraco-abdominal or any abnormal breathing type of pattern, that is a giant stroke breathing, paradoxical breathing. We'll get to know different type of abnormal breathing pattern in a later on lectures as well. Whether patient is having a swelling, edema which is present, involuntary movements, like whether patient is having a tremors, that is continuous movement would be there, whether patient is having a dystonia, whether patient is having a chorea, whether patient is having a nystagmus, that is a eyeball movement. So whether any involuntary movements are present or not, that also we need to ask. Then we can talk about the trophic changes, whether it's a dry, scaly, shiny skin, as we can even see in adult or geriatric people. If we can see their skin, it will be more fragile skin, very thin skin and very scaly skin would be there. Like if we just tear, there is more chances that it will tear off very easily. Then deformities, like any of the deformities are present or not. Then behavior of the patient. बहुत बार हम बोलते हैं कि हाँ पेशेंट कोऑपरेट नहीं करता है, पेशेंट बहुत इरिटेटेड है, पेशेंट बहुत गुस्सा करता है. So how the patient behavior is, according to that we can treat the patient. Obvious muscle wasting, as if we are not working since long time, patient is bedridden for a long period of time, definitely there will be chances that muscle wasting occur due to the muscle fibers are going to be atrophied, and due to that patient would be having a muscle wasting. Facial expressions and general appearance of the patient. Facial expression important, like if patient is having stroke, so along with stroke patient is having a Bell's palsy, facial palsy which is present or not. So for that we need to know this. Then comes with on palpation. So on palpation we can start with tenderness. First and most important thing we need to know about the tenderness, whether on the touch, whether patient is having a pain or not. So we need to grade that, whether the tenderness is present or not. If yes, where it is present, exact the site or exact the location of that, and we need to know the grades. Whether there is a simple pain, whether patient is having pain with winces, whether patient withdraws, that is grade 3, and whether patient doesn't allow to touch. Like if we even try to touch, patient is saying no, you cannot touch, it's much more painful. Then warmth, sometimes it happens in many of the condition, like affected side and non-affected side. If I talk about neuro, so there are many cases in which the warmth or the temperature will be different. That is depending on so many functions or the lobes which is regulating the temperature, but due to that also it can affect. So we need to check that as well. Tone, whether it is flabby or whether it is hard. Like whether it's simple, you can feel the soft muscles are there, you can consider that is hypotonic, or the muscles are less moving, muscles are more flappy kind of, and hard you can feel it, that is a more hypertonic. If you do a movement, you can feel somewhat resistance in that, so that will be more like it is a more hypertonic. Edema, whether it is a pitting edema or non-pitting edema, we'll see that when we are pressing it, whether it is comes back or whether it is not coming back. On that basis it depends on pitting or non-pitting edema. Okay, so we are clear with this, all this portion, that is demographic data on observation and on palpation. So just a brief some questions. Let me know that while observing a stroke patient, you notice a circumduction gait and flexed upper limb posture. This observation suggests cerebellar lesion, peripheral neuropathy, whether it is a hemiplegic gait or whether it is a Parkinson's gait. What would be the answer? Anyone can give? I can wait for 2 seconds. Yes, so it would be there in a hemiplegic gait. As I told you, will be having a posture of upper limb would be like this, and patient will be having a circumductory gait. That is most common in a hemiplegic portion. Hemiplegic gait. Yes, correct. Answer C. Thank you. Okay. Next is on palpation. Next question is, a limb feels hard and resistance to passive movement. This indicates, first is flaccidity, whether it is hypotonia, whether it is hypertonia or atrophy. Again, you can feel that whenever we are doing a palpation, it is feeling very hard and resistance to the passive movement. What could be the answer? Answer C, that is hypertonia. Yes, that is correct. Patient would be having hypertonia because it is difficult to do a movement. Okay. Now the major important portions we are going to start with, that is higher mental functions. Most important thing whenever we are taking a case of neurological assessment. First important thing, whenever you see any particular patients of neuro, we need to check a level of consciousness, whether the patient is conscious or not. That are having so many stages. We'll go one by one, and then after we'll see the answers of that as well. So first important thing, whether you go in ICU and you see a patient, and you can get to know whether the patient is conscious or not, how the patient is reacting, what are the functions that patient can do. So for that we need to know the level of consciousness. You can see. So these are the particular stages, that is alert, drowsy, stupor, confused, delirium, and whether the patient is in comatose stage or not. Then after we will get to know, for that the major and most important scale still we are using, and that is more clinically, most important clinically, that is GCS, that is Glasgow Coma Scale, which we need to take. Just a second. That we are going to see later. Then after we are going to check about the orientation. So orientation we need to know so that we can aware of the patient, whether patient is oriented to time, like हम patient को पूछे कि आप कहाँ पे हो या कितने बजे, तो patient is well aware कि हाँ सुबह है या शाम है, तो we can get to know that we can contact or we can talk with the patient. Time, place and person. So we can ask about the time. If patient is not able to tell the exact time, we can even ask whether it is morning, whether it is noon, whether it is evening. Then we can ask about the place. We are not going to ask about the exact location, that in which area or which particular you are, but we can ask whether you are in hospital, whether you are at home, whether you are in which city, if patient is knowing. So we can ask about the place and person. Like if someone is standing beside the patient, we can ask patient that who is this? Is it your mother? Is it your father? Is it your husband, wife? So we can get to know about the relation. So we can get to know that whether the person is able to connect with them or not, whether patient is. From these questions, we can get to know that patient is oriented. Along with that, we can get to know whether the patient's memory is good or not. That is another thing, but we'll get to know. So for all these higher mental functions, we'll having another scale that is known as MMSC, that is mini mental scale examination, that we are going to take for orientation, for registration, for attention and calculation, recalling and language. For all these portions, we'll be having mini mental scale. These are the questions that we are going to check into the patient, and we are going to score accordingly. This is a basic interpretation score of the MMSC. Like if it is more than or equal to 27, this is no impairment. If it is 21 to 26, that is a mild impairment. If it is 11 to 20, that is moderate impairment. And if it is less than 10, then it will be having a severe impairment would be present. Okay. So the next question is, a patient remembers childhood events clearly but forgets what he ate in the morning. So this, which memory is impaired? We are going to learn about the memory as well, but this is just I want to know that whether you know about memory or not. So the options of this, that is a remote memory, long-term memory, immediate memory and recent memory. So what could be the answer for that? At patient is able to remember the childhood events, but patient forgot what he ate in the morning. Whether it is I can say the answers, remote memory, long-term memory, immediate memory and recent memory. Yes, answer is recent memory, like patient is not able to reply. Yes, Meenal, your correct answer. Okay, so now as I told you about the consciousness, so we are going to check about the stages of consciousness of GCS scale and attention. So these are the basic stages of consciousness, starting with alert, then drowsy, then stupor, then confused, delirium, and last stage is coma. Now, what are these different stages? And on these stages, different questions in the exams also can be asked. So, first is arousal. What is arousal? So, it's a physiological readiness of the human system. As we are aroused, we are awake, we are well oriented, we know where we are, what we are doing the things. So, we can get to know that about the arousal. Now, first is alert. As I can talk about ourselves. So, we are good alert. We know where exactly we are, what are the things we are doing. We are properly awake. We are attentive to the normal levels of stimulation, and therapist can talk us to the normal and we can respond in a normal way as well. Like whatever the question has been asked to us, like कोई मुझसे पूछेगा कि नाम क्या है या आप क्या कर रहे हो, तो I can answer that. Fine. So that is a alert stage. Now second stage is lethargic stage. Now what happens in lethargic stage? So what happens? Patient appears drowsy. Like patient को जब भी देखेंगे हमें feel होगा कि patient almost सो रहा है, like drowsy, and may fall asleep if not stimulated in some way. हम उसको जगाएंगे नहीं तो वो majority सो जाएंगे. Fine. Interaction with the therapist may get diverted. Patient may have difficulty in focusing or maintaining attention on a question or a task. Like हम जब भी patient के पास जाएंगे, हमने patient को उठाया कि हाँ उठो, बोलो, आपका नाम क्या है, तो patient will respond. But we need to give a stimulation to the patient, then only patient will respond, and patient will be more drowsy. So this is the most important thing, that is we need to, patient would be much drowsy. Next is obtundate stage. These are the important stages of consciousness, because on this basis question would be asked. We can give in a case history and will be asked as which particular stage is there. The patient is difficult to arise from a somnolent stage and is frequently confused when awake. Like majority patient will be difficulty aroused. बहुत कोशिश करनी पड़ती है तब जाके patient जगता है, and then we need to know. Yes, Dhruv, I can explain the other memories as well. As today I am going to talk about more on consciousness. There are so many memories and the defects of memories are there. So we can talk about that as short-term memory, immediate memory and long-term memory. If I talk about the immediate memory, so for example, I can give you 3 objects. That is whether it's an apple, banana and chair. So patient has to immediately call these 3 names or the 3 object names. That will be immediate memory. If it is a short-term memory, so I can ask patient that what you had done in a breakfast. Like if I am meeting patient around 10 or 11, I can ask to the patient, आपने सुबह क्या खाया था, या 10 मिनट पहले मैंने आपको कौन से 3 वर्ड्स या कौन से ऑब्जेक्ट्स का नाम बोला था. तो दैट इज शॉर्ट टर्म मेमोरी. एंड इफ आई एम टॉकिंग टू द पेशेंट ऑफ लॉन्ग टर्म मेमोरी, लाइक आपका नेटिव कौन सा है, आपकी बर्थ डेट कौन सी है, या व्हाट इज योर मैरिज एनिवर्सरी डेट और एनी पर्टिकुलर इंसिडेंट, सो दैट विल बी कनेक्टेड एज इन लॉन्ग टर्म मेमोरी. If patient is having issues with memory, patient might be having amnesia, that is a memory loss. There are different things, that is a retrograde amnesia, that is anterograde amnesia, that occurs due to the injury. Patient is not able to recall certain events after the injury, or patient is not able to create new events of that. So that is called as in retrograde and anterograde amnesia. These are the different type or diseases of the memory which occurs. Gradually, once a patient is having Alzheimer's disease, in that also patient is having a memory issues. Patient is not able to remember something. Patient is easily forgetting something. So those are things which will be also present. Dhruv, whether it is clear? Okay. So come back to the stages of consciousness. Obtunded. So patient is difficult to arouse from a somnolent state and is frequently confused whenever the patient is awake. Repeated stimulation is required to maintain consciousness. Like बहुत बार जगाना पड़ता है patient को जब भी हमें कुछ पूछना हो. And interaction with the therapist may be largely unproductive. Like हम पूछेंगे फिर भी patient will answer or not, we are not sure of that. So there will be chances patient is not giving proper answers. So that is obtunded. This is a most common thing or common difference between your lethargic and obtunded state. Lethargic is patient is able to answer but patient is drowsy. Obtunded is patient is drowsy but also difficult to arouse and also confused whenever the patient will be awake. Fine. Next stage, that is a stupor stage or semi-conscious stage. Very important stage. If you go in ICU, you will see majority of the patients are in stupor stage, like if the injury is much more. So, the patient responds only to strong, generally noxious stimuli and return to the unconscious state when stimulation is stopped. What does that mean? Whenever we are giving any particular painful stimulation, painful stimulations will be given at a different areas. Either we can give it on the supraorbital, we can either give the painful area or painful stimulation at the sternal notch, either we can press a nail bed or either we can pinch a belly of the muscles, whether this or whether calf muscle. And on the response of that, we need to know whether the patient is opening the eye, whether the patient tries to speak or whether the patient is doing any particular movement. So, if patient responds only to this particular painful stimuli, then it will be considered or we can get to know that patient is in stupor stage. Then next is coma, that is a deep coma stage when patient doesn't respond to at all. Patient cannot be aroused by any type of stimulation. Reflex motor response could be there, like any of the reflexes or associated reactions could be there, but other than that, patient won't be showing any kind of responses. Okay, so to know about this consciousness, we are going to take about the GCS. So how this GCS will be working, that is Glasgow Coma Scale. It is developed by Tesked and Janet, is the most widely used clinical scale that measures the level of consciousness and helps define and classify the severity of the injury. In GCS, we are going to check about the major three important things that you can see here. First is eye opening, second is your verbal, and third is a motor response. Eye opening response, like whenever we are doing or whenever we are giving any commands, whether the patient is opening the eyes or not, whether we are giving stimulus, we are calling the patient, we are touching the patient, we are giving painful stimulus, whether the patient is giving verbal response or not, and last is motor response. So with the help of this, we can get to know. Always remember, eye opening is having 4 grades, verbal will be having a 5 grades and motor would be having a 6 grades. So first is eye opening. Eye opening would be having a 4 grades are there. So you can see here that is a spontaneous. Like for example, if I am going to the patient, patient is not sleeping, patient is just lying on the bed, and if I am looking or I am just going in the room and patient opens the eye, so that will be a very quick response. That is a spontaneous response would be there. Fine. Next, for example, patient is not responded when I entered in the room or when I entered near to the patient, then I am calling the name. Like मैंने बुलाया उनको patient को या कुछ भी रमेश भाई या कुछ भी patient और कैसे हो आप या उठिए. So just to speech, I am not touching patient, just to speech or just to my verbal command, if patient is responding, that will be considered as in grade 3, that is on to speech. Then comes with 2 pain. as I told you earlier, if we are giving any noxious stimulus to the patient, like I am pressing a sternal notch or if I am pressing a nail bed and patient is trying to open the eyes, then it will be considered the patient's GCS on eye opening, it is grade 2. And though I am doing all the things, still patient is not responding, that will be considered as in grade 1. Always remember, GCS cannot be 0. GCS minimum score is, GCS minimum score is 3 and maximum score is 15, because GCS is always written as EVM. Fine. E, that is eye opening, that is 4, V is 5 and AM, that is 6. So minimum response in all these 3 is 111. So the basic or very minor minimum response would be 3 and maximum, as you can do a total of this 4 plus 5 plus 6, that would be a 15. So that is a major or the maximum score of the GCS. We are having a scoring of that as well, but this is a very basic. And this is how you are going to write a GCS in any of the patient. If the patient is ICU, you have to check GCS on a regular basis. This could be changed according to the patient condition. Not necessary that, for example, सुबह patient का GCS लिया और शाम को लिया तो same आए. There would be chances कि थोड़ा बहुत ऊपर नीचे या differ हो सकता है. Fine. So other important thing, like for example, कभी कभी question होता है कि अगर patient बोल नहीं पाता हो तो specifically हम ICU में देखते हैं तो there will be chances के endotracheal tube या tracheostomy किया है patient को. So what we are going to do in that, we have to write either, if it is tracheostomy, we have to write T, either it has been endoscopy, ET tube, so we have to write ET tube, sorry, not endoscopy, that is ET. So we can write whatever the eye opening response, whatever the motor response, and on V, we can write about the T or ET, that is tracheostomy or ET tube has been inserted. Okay. So this is all about the eye opening. There has been 4 gradings of that. Always remember, 1 is no response, 2 is on pain, 3 is on speech and 4 is spontaneous. Now we talk about a verbal response. So as verbal response will be having a 5 response. 1, always remember from 1 to 5. Fine. So 1 is no response. Though you do anything, patient doesn't respond at all. Second, incomprehensible sounds. Incomprehensible sounds, that means patient is speak anything. Might be you have observed in ICU that patient speaks any random words, any different words or any different sounds, different kind of sounds patients will be making. So that is incomprehensible sounds, and if it is there, it will be considered as in grade 2. If it is inappropriate words, patient, we are asking something, patient is giving some different answers. But inappropriate words, like continuously किसी का नाम बोलते रहते, कुछ भी बोलेंगे, कुछ भी याद आया कि हाँ ये हुआ है. So those particular inappropriate word patient will be using. So then it will be considered as in grade 3. Then comes with grade 4, that is confused. मैं पूछ रही हूँ patient को आपका नाम क्या है, patient बोल रहा है मैं hospital में हूँ. Fine. So what questions we are asking and we are getting a different response. So that will be considered as in grade 4. And grade 5, that is oriented. मैंने नाम पूछा, पेशेंट ने अपना नाम सही बताया, पेशेंट कहाँ पे है बोला, so that is considered as in grade 5, that is oriented. Clear? So eye opening is having a 4. 1 is no response, 2 is on pain, 3 is on verbal speech and 4 is spontaneous. This is for eye opening. Now if I talk about the verbal, so that would be having a 5, that is 1 is no response, 2 is incomprehensible sounds, 3 is inappropriate words, 4th is confused and 5th is oriented. So these are the 5 gradings which will be there for the verbal response. Now we go for a motor response. So motor responses is 6. As I told you, there will be E4, V5 and 6. So this is the 6. So motor response would be having a 6 grades. Now as always, grade 1 is no response, as we had seen in eye and verbal. Grade 2 would be decerebrate posture and abnormal extension. If patient is maintaining that posture, then it will be considered as in grade 2. If it is decorticate, so then it will be considered as an abnormal flexion, that is considered as in grade 3. Next is withdraws. When we try to touch and patient withdraws, that is grade 4. When patient can localize the pain, that is grade 5. कि यहाँ पे पेन दिया या टच किया और पेशेंट दिखा रहा है हाँ मुझे यहाँ पे टच किया यहाँ पे पेन हुआ, that is grade 5. And grade 6, that is obeys command. So if patient is responding like this in a motor response, this will be considered as in grade 1 to 6 for verbal response. So this is how the GCS will be scored. That is eye-opening, verbal response and best motor response. That is 4, 5 and 6. The minimum is 3, maximum is 15. Interpretation, as I told you, the minimum score is 3. So if it is 3 to 8 or less than 9, this will be considered as in severe brain injury. Majority of the patient would be having a more issues with the consciousness of the patient and patient is having a more difficulties. If it is less than 8 or 9 or less than that. If it comes between 9 to 12, then it is considered moderate. And last, if it is more than or equal to 13, then it will be considered patient is having a minor brain injury. Like patient का अगर eye response 3 आया, patient का verbal response 4 and motor response is 6, you can consider 6, 4, 10, 13. So patient 3 is 3 क्या था? 3 response क्या था patient का eye opening पे? So patient will be responsible with the verbal. V4, patient is responsible and motor is 6, that is a full obeys command. So if it is 13, that is considered as an minor brain injury. Fine? Yes, spontaneous is grade 4, Dhruv. Grade 3 was on speech or on verbal. You tried, good, but eye-opening grade 4 was spontaneous. Fine? Okay, now the question. A patient responds only to the painful stimulus and immediately returns to unconsciousness after removal of stimulus. He is unable to interact with the therapist and this level of consciousness will be called as an drowsy, confused, stupor or coma. Now you tell me that what would be the correct answer, as I had given an explanation also, but still. Next time I had done this, but next time I'll make sure that the answer would be in the next slide. As patient is respond to only painful stimulus. Answer B, that is confused, have. Answer D, that is coma. No, patient responds to painful stimulus. If patient is in coma, patient doesn't respond. Answer C, yes, correct. That is answer C, that is stupor. Because patient only respond to painful stimuli and immediately returns to unconscious after removal of stimulus. जब हमने stimulus हटा दिया, वापस patient semi-conscious में चला जाएगा. Fine. So that is a stupor stage. Yes. What's your name? You're correct. That is Arzu, I guess. Yes. That's the answer C. That is a stupor stage. Nice. Okay. The next is a patient open eyes to the pain, makes incomprehensive sounds. You can even note down and you can calculate it. And withdraws to the painful stimuli. Now consider or calculate what would be the GCS. Again I am telling, patient opens eyes to the pain. Pain would be, yes, eye to pain would be second grade. Fine. Then we'll be having a makes incomprehensible sound. Incomprehensible sounds कौन सा था? Grade 2. 1 था no response verbal में, 2 था sound, 3 था inappropriate words. Fine. So 2 is incomprehensive sounds. And withdraws to painful stimulus. Withdraws कौन सा था? 4. Yes. So the total of the GCS would be 2, 2 and 4. That is, the total is 8. 8 is having minor injury, major or minimum injury, mild, moderate or severe. Yes, it is severe injury because it's a 8 scoring. Fine. Yes, major brain injury. Correct. Fine. Okay. Now the next question. A comatose patient shows decerebrate posturing. What is the motor score? I told you about decerebrate and decorticate. So patient is having a decerebrate posturing. What would be the motor score? The answers. Yes, I am letting you the answers. That is 1, 2, 3 or 4. Which particular motor score? 2. Yes, correct, Dhruv. That is grade 2 because it is having a decerebrate posture. If we go about a more, it is grade 3, that is decorticate posture. If I had asked you about the decorticate, it could be 3. Fine. Okay. Now we talk about the attention. So how the attention will be, what is attention and how it is working. So basically attention is an ability to select and attempt to specific stimulus while simultaneously suppressive the external stimuli. Like we are just focusing on the particular stimulus and we are avoiding the more external stimuli, that is called as an attention. So a patient who is inattentive or distractible, जब हमको होता है ना क्लास में थोड़ी देर में हमको नींद आती है, मजा नहीं आता है, तो क्या होता है, अटेंशन नहीं रहता, फोकस नहीं रहता हमारा. So they will be having a more difficulty in new information or technologies टेक्निक्स. उसमें क्या होता है, फॉर एग्जाम्पल लेक्चर लिया, हम सो रहे थे, हमारा ध्यान नहीं था, सडनली हमको कुछ पूछ लिया तो नहीं आएगा. क्यों? बिकॉज वी आर नॉट गिविंग फोकस्ड अटेंशन. फाइन. So patient who are suffering from a particular conditions like CVA, that is cerebrovascular accident, head injury, aging, will have a low arousal levels. Like इतना easy उनका और इतना attention नहीं होता है, and require a great deal of sensory input to be alerted to the environment. Many a time it happens with us and the patient. Like हम patient को जब treatment करवाते हैं, that time what happens? Patient doesn't react much. और पेशेंट कभी कभी भूल जाता है, पेशेंट को हम करवा रहे हैं कुछ, पेशेंट रिस्पॉन्स नहीं करता है. फाइन. सो व्हाट हैपेंस ड्यू टू दैट, पेशेंट डज नॉट गिव प्रॉपर अटेंशन. सो वी नीड टू अराउज पेशेंट अगेन एंड अगेन. बोलना पड़ता है, यहाँ पे ध्यान दो, ये करना है, खड़े होना है, आपको ये करना है. फाइन. So these are the particular things because of the affection which occurs in the brain. Due to that, they are having a lack of attendance, lack of attention. Okay. So multiple brain regions are important to require attention. Specifically, this include our reticular formation, that is more important for the arousal of the patient. Whenever we see a patient, whether it is an aroused, not properly aroused, we need to check about it. Whether it is a reticular formation, sensory systems or limbic and frontal regions. These are the specific lobes which is maintaining our attention. Okay. Now, these are the major type of the attention we need to work on it. So, this is 4 type of attention, that is first is sustained attention, second is alternating attention, then selective attention and divided attention. Fine. So, these are the 4 different type of attention we'll have. Okay. So, now the question. Which structure is most important for maintaining arousal and attention? Whether the answer is hippocampus, reticular formation, basal ganglia or cerebellum. I had just told this right now. I can tell that this is immediate memory. Abhi bola hai. What could be the answer? Which structure is the most important for maintaining arousal and attention? Hippocampus, reticular. Answer B. Reticular formation. Okay. Yes. Yes, that is correct. As reticular formation is important because hippocampus, basal ganglia and cerebellum is having a different functions. Fine. Okay, next question. Damage to the frontal lobe will most affect which particular domain? Whether it is orientation, whether it is attention, whether it is memory or language. What would be the answer? Yes, that is also answer B. Yes, attention. Fine. Frontal lobe is also maintaining our major attention. So, the damage to the frontal lobe which also goes into attention. Okay. No, orientation is not always by the frontal lobe. It is attention. So, the first type of attention, that is sustained attention. What is this? So, it is a capacity to attain to the relevant information during activity. It required consistent response during the continuous activity. Like for example, हम पढ़ रहे, लिख रहे, कुछ भी task कर रहे. So, how much time we are engaged in one particular activity, that is sustained attention. That is ability to focus on particular task for particular period of time. हम बोलते हैं ना 45 to 50 minutes हम lecture में ध्यान दे सकते हैं. कुछ भी काम करो, we can give that particular time of period. So that is our sustained attention. Definitely that depends on the activity as well. Patient with a disorder of sustained attention may report that he or she starts to watch a TV program and then just drift off. उनको suddenly ऐसा feel होता है कुछ काम कर रहे हैं कि नींद आ रही है या कुछ और देखना है. Fine. So they cannot focus on that attention. जब भी उनका distractions होता है. Fine. हमको होता है ना पढ़ते पढ़ते थोड़ी देर में ख्याल आता है फोन देखना है, ये करना है. तो that is we cannot able to maintain our attention or that is not for a longer period of time. तो हमारा sustained attention कम है, उसका short span है. Next is either focus or either selective attention. Selective, जैसे selective listening होती है, हमें जितना सुनना है उतना सुनते हैं. The same way attention is also having a selective attention. So it is a capacity to attend a task despite of environmental, visual and auditory stimulus. बाजू में ढोल नगारे भी बजते हो, पर अगर हमें नहीं सुनना है तो हम उसको नहीं सुनेंगे, और अगर हमें वही सुनना है तो हम वही सुनेंगे. Like what we need to focus or what we are selecting, that will be called as in focus or selective attention. Particularly that focus on one stimuli, and it often referred to as distractibility. कितना distractions आता है उससे होता है. Fine. Like if I tell you कि यहाँ से तुमको पढ़ना है red color में क्या लिखा है. Fine. So you need to give a focus that red color में लिखा हुआ क्या है. So that will be blue and black. Fine. If I talk about कि green color में क्या लिखा है. Fine. So that is red and blue. So that is selective attention. You need to select while I need to ignore कि भले red green color में red लिखा है, but I need to focus कि green color में क्या लिखा है. Fine. So a patient who has to stop dressing activity, ये हमारे साथ बहुत होता है. जब हम पेशेंट की हिस्ट्री लेते हैं या पेशेंट से बात करते हैं, तो होता है कि पेशेंट फॉर एग्जांपल एक्सरसाइज करते करते अटक जाते हैं. सो दैट इज पेशेंट एक ही जगह पे ध्यान दे रहा है, पेशेंट दोनों जगह पे फोकस नहीं कर रहा है. फाइन. सो पेशेंट विल बी हैविंग डिस्ट्रैक्शन विद दैट. पेशेंट इज हैविंग अ प्रॉब्लम विद दैट. So these patients are who are easily getting distracted or disturbed by the music or any other form of background noise, or may also experiencing problem with the focused attention. Fine. They cannot focus on something. हमें होता है ना पढ़ते अगर कुछ suddenly आवाज आए तो ये लाइक बंद कर, उसको नहीं सुनाई दे रहा है. Fine. We can test this by a digit span test. This is the most important or good test we can take to check a attention. Fine. What we have to give in digit span test? We have to give a random numbers to the patient or to the client. Like we can ask about 7, 5, 3, 4, 9, 11, 12, 1. And we need to give this 10 numbers to the patient. When we give this 10 numbers, we need to ask patient to repeat that. Once patient is repeating that, and if patient can answer that 7 forward numbers, remember this, 7 forward numbers and minimum or max 5 backward numbers. So that is considered that the patient attention is good or better. Fine. In the same sequence. Fine. If I tell the patient कि patient को repeat करना है 3, 4, 5, 7, 8, 10, 12, 11 and 1. Fine. If patient responds good with this 7 and backward this 5 numbers, then we can consider that patient selective attention is good. Okay. Now this is a third type, that is alternating attention. What is alternating attention? Switching from one task to the another task. कि अभी मैंने पेशेंट को बोला क्लैप करना है, उसके बाद आपको वॉक करना है. So switching between two tasks, that will be very easy for the patient, that it will be considered as an alternating attention. दोनों साथ में नहीं करना है, एक के बाद एक तुरंत करना है. Fine. So that is alternating attention. So it is the capacity to move flexibly between the tasks and respond appropriately to the demand of each task. कि मैंने बोला वॉक किया, अभी क्लैप करो, वापस वॉक करो, फिर क्लैप करो. Fine. If patient responds to these activities, then it will be considered as an patient is having a good alternating attention. That is switching between two tasks very easily. That is, for example, addition and subtraction. पहले कुछ addition किया, फिर उसका subtraction करो. Whether pegboard task, walk किया, उसके बाद थोड़ा सा pegboard task करो, फिर वापस आओ, or clapping and counting. Fine. So these are the some of the things which can be done. Yes, Bhumi, I remember you. Okay. Next is divided attention. So this is a capacity to respond stimulus two or more different tasks to the stimuli when we are giving a stimuli. That is, best example is driving. Fine. That is divided attention. Fine. What happens when driving? While we are driving, our hands are working. Whether we are driving a two-wheeler or four-wheeler, we are seeing the road. We are also hearing the music. So our auditory system, our visual system, our motor system is also working. So more than one or two systems which will be working, and still we are able to manage the task, that was considered as a divided attention. Fine. Like walking with talking, हम चल भी रहे हैं, बात भी कर रहे हैं, हम साथ में कुछ आया तो उसको भी respond कर रहे हैं. Fine. So those all things will be considered. Cooking, cook कर रहे हैं, साथ में काम कर रहे हैं, बात कर रहे हैं, कुछ साथ में काम कर रहे हैं. So multiple systems are working together. Fine. So if more than two systems are working, then it will be considered as a divided attention. So patient who is having difficulty in divided attention, majority of the difficulties they will be having in their daily activities or day-to-day activities, because they cannot easily do the multitasking. हम बोलते हैं ना, इससे multitasking नहीं होता, इसको एक चीज पे ही ध्यान रखना पड़ता है. फाइन. तो क्या होता है, divided attention इतना शार्प नहीं होता जितना होना चाहिए. Okay, now it's your time. So question: a patient is unable to continue dressing when therapist is talking to them. Which type of attention is impaired? Whether it is sustained, whether it is selective, whether it is divided or alternating. Patient stop doing activities when we start talking, or patient stop doing dressing or any of the activity or any of the tasks which they are doing. Option B, selective. Okay. Yes, correct. This is option B, that is selective. Is I given a same example, like if I'm talking to the patient, patient will stop doing the activity, or if patient is doing dressing, patient will suddenly stop. Okay, now the next question is, normal digit span indicates good selective attention when patient can repeat, that is 5 forward and 3 backward number, 6 forward and 4 backward numbers, 7 forward and 5 backward numbers, and 8 forward and 2 backward numbers. Answer C. Yes, that is a 7 forward and 5 backward numbers, 7 and 5. That was there in a digit span test. Fine. Sorry. So that was there in a digit span test. Correct answer, that is answer C. Okay, now next question. A stroke patient is alert but cannot concentrate, fails digit span and get distracted by the background noise. Which attention domain is mostly affected? Whether it is sustained, selective, alternating or divided. I am repeating the question. A stroke patient is alert but cannot concentrate. Alert है patient but concentrate नहीं कर रहा है. Digit span fail, not working properly, and get distracted by the background noise. What could be the answer? That is sustained attention, selective attention, alternating attention, or divided attention. That is option 1 is telling option B, second one is telling option D. Okay, we'll wait for another is B. Okay, so the majority option is B, that is selective attention. Okay, we check, I'll just move and you can get to know. Yes, it is a selective attention because patient is getting distracted by the background noise. That happens usually with the selective attention. Fine.
Explain formal to attention.
Okay. Yes, I'll explain. Okay. As we talked about so these are the basic type of attention. The second type of attention which was there is a focus attention or selective attention. The first was sustained attention. Second was focus or selective attention. Yes, I can read your question. That is, first is focus. Second is, first was sustained, second was focus or selective. In that, patient will be getting distracted easily by the background noise or something. Patient will stop doing activities while we talk or we ask them to perform any of the thing. Then comes with alternative, that is switching between the two tasks, and last one is divided. Fine. So, multiple systems will be working together and patient is working for that. I hope you are clear now. So, these are the major type of attention. Now, as we talk about the memories, we already talked, that is recent, immediate, short-term and long-term memory. Then we will be having a different speech. We are going to learn about the speech in more detail then in the next. But these are the specific different speech affection would be there. Whenever the patient speaks, we need to know whether it is patient is having difficulty with motor, patient is having difficulty with sensory, whether patient is having a more difficulty with expressions. So, what kind of problem is that we need to ask to the patient. Fine. Like if I am just giving you a brief of that, these are the different speech affection which occurs into the patient. That is Broca's aphasia, Wernicke's aphasia, conduction, and this is a global, which is a combination of all these things. Now, whenever we are assessing a speech, these are the three main important that we need to see. Whether it's a fluency, whether how the comprehension of the sounds are there, and repetition. Fine. So, first is Broca's aphasia. Broca's is also considered as a motor aphasia, where the motor component is more affected. So, fluency will be reduced, comprehension is somewhat normal, and repetition is also reduced. If it is Wernicke's, that is sensory aphasia, the speech or would be fluent, the fluency will be good, but comprehension would be poor and repetition will be also less. If I talk about the conduction aphasia, fluency is also fluent, the comprehension is also normal and repetitions will be poor. And if I talk about global, all the things is going to be impaired. The fluency of the patient, the speech, comprehension of the sound as well as repetition of that. Fine. So, all the three things will be affected. Then comes with general intelligence. We don't need to ask a hi-fi questions to the patient. We can ask very basic questions to the patient. Fine. So that we can get to know whether the patient is aware about all the things or not. नहीं पूछना है कि हाँ के मंत्री या कौन थे, इतना deep नहीं जाना है. But simply we can get to know so that we can answer patient is proper or not. Yes, your question is sustain versus selective. Sustain is when we are focusing on something, and selective, that is we are focusing on one particular task while we are ignoring or we are not focusing on the other external stimuli. Sustain is, for example, if I am writing and I am able to write that for 30 minutes, so my sustained attention is taking for, or my sustained attention is for 30 minutes. But if I am focusing or I am writing, along with that, if there is so much noise which is going on background, but still that doesn't affect me, I am going to still write on that, fine. So that is my selective attention, that I am focusing on writing, that is my selection which I has been selected, and I am ignoring the other things, that is considered as a selective attention, fine. So this is about sustained and selective attention. I hope it is clear now. Okay. The next is calculation. Calculation is considered as a major higher mental functions which requires a good amount of higher mental functions into the patient. So in that we need to ask a simple calculation, not so many subtractions and addition we need to ask to the patient. We just need to go for a basic sum of the patients. So that we can consider according to the educational level and capabilities of the patient. अगर patient ज़्यादा गिनती ऐसा कुछ नहीं आता तो simply हम पूछ सकते हैं कि इतने पैसे आपके पास से इतने किसी को दिए या इतने add हुए तो कितने होते हैं, so that we can get to know about the basic things of the patient, right? Another important thing that is insight and judgment. Insight and judgment. Insight is feeling of own self. Patient को पता है उसको खुद क्या है, fine. So that is insight. Like, do you think you are ill or why are you admitted? कभी कभी ऐसा होता है कि like when we are asking patient some of the question, patient is like मुझे कुछ नहीं हुआ है, I have no problem, I don't have any issues, fine. Patient is not even admitting that something has been happened or the hand is not working or he's having some of the issues, fine. So this is to know whether patient is aware about his condition or not, whether patient is knowing that these are the things which occur or which happens to me. So that is insight, that patient is having their own feeling. And second is judgment. That is simple questions or simple scenarios we can give to the patient. Like for example, आपको यहाँ से पहुँचना है घर, तो आप कैसे जाओगे? ऐसा कुछ सीन है तो what you will react? Fine, simple कोई चीज हम देके बोल सकते हैं. Yes, sustained attention is for a longer time. That is a more longer period of time. Okay. So for judgment we can ask, what will you do if you find a wallet? हाँ, हम पूछ सकते हैं अगर नीचे पैसे गिरे हो तो क्या करोगे? सिंपल क्वेश्चन पूछना है, उसमें बहुत लॉजिक नहीं लगाना है. लाइक वी कैन आस्क इवन कि अगर आपको यहाँ से घर जाना है तो आप कैसे जाओगे? यहाँ से ऑटो पकड़ोगे या कहीं और से जाओगे? व्हाट कुड बी द वे दैट हैज बीन चूजन, राइट? Then next is reasoning and problem solving. These are considered as in higher mental functions, like these are considered as in more executive functions which requires a good dealing. हम बोलते हैं ना इसका decision power अच्छा है या he or she can deal with those things, fine. So they require a good things, they have a reasoning, like ये होगा तो ये reasoning हो सकते हैं या this could be the things. So these are the problem solving or reasoning needs to be done, or simple questions can be asked accordingly. Behavior, that is what kind of attitude of the patient, whether patient is cooperative, whether patient is having some of the issues, emotional issues, that can be also due to the issues which occurs within the brain or any other particular condition. So we need to understand that what is the condition of a patient, and then we can treat the patient and we can talk to the patient accordingly. And we need to know about the emotional status of the patient, right? So whether patient is depressed, whether patient is euphoric, कुछ अलग ही zone में होते हैं, euphoric stage में होते हैं, whether patient is calm, emotional lability or fearful. कुछ पेशेंट होते हैं ना जो खुद बहुत मोटिवेटेड होते हैं, हाँ मुझे चलना है, मुझे वॉक करना है, मुझे ये करना है. कुछ पेशेंट इज लाइक नहीं मुझसे तो नहीं होगा. कुछ पेशेंट्स लाइक हो जाएगा, थोड़ा टाइम है अपने पास, आराम से करेंगे, धीरे धीरे करेंगे. एंड सम पेशेंट्स वुड बी लाइक नहीं, आई कैन नॉट स्टैंड, मैं खड़ा नहीं हो सकता, मैं गिर जाऊंगा, या दे विल बी हैविंग मोर फियर ऑफ मेनी ऑफ द थिंग्स, फाइन. This emotional status we need to know because we are going to deal with the patient on that particular basis. So if patient is having a fear, we need to reduce the fear by different manners or different treatment approaches with the use. If patient is more of lethargic or patient is not doing, due to that patient condition will be more deteriorated, fine. So we need to know about it. Fine. So the next question is, first I need to hide the answer. Okay. So a 30-year-old male with a road traffic accident, on examination, patient open eyes only to the pain. Now tell me, only to the pain will be grade of 2. Fine. Makes incomprehensible sound. That is also 2. Right. 3 was inappropriate word. 2 is incomprehensive sounds. Withdraws from painful stimulus, that was 4. We had done this before as well, if you remember. This MCQ I had even added, but I just need to reconfirm that whether you are okay or not. Yes, so the total score would be 8. So what would be this GCS? The answer is B, that is 8. Okay. Now the next is, patient does not open eyes, produces no verbal response, and patient will be having a decerebrate posturing. That is also grade 4, because does not open eyes, that is no response, is grade 1. No verbal response, that is also grade 1. And decerebrate posturing is grade 2. Fine. So the total score is grade 4. That is also having a severe brain injury. You can correlate like this. Okay. Now, a intubated patient obeys commands and open eyes to speech. Obeys command matlab ho gaya grade 6. Eyes to speech matlab grade 3. What is the correct way to record verbal response? Fine. Remember, the patient is intubated. Already patient ko tracheostomy ya ET tube hai. So what could be the answer? That is either 1, 2, T or not accessible. So you need to write T, because already the tracheostomy or the intubation has been done. This kind of tricky questions would be there. Like they'll give you all the hint and one particular word has been given. So whenever you are writing or whenever you are giving answers in the exams, make sure that you read your questions thoroughly. Read each and every word of the question. Then you can understand what exactly question has been asked. कई बार ऐसा होता है, बाहर जाने के बाद हमें पता चलता है, कि उसमें नॉट लिखा था जो हमने देखा ही नहीं. फाइन. Which option has not been selected for this? ऐसा भी पूछते. So this is a one type of that question. Like intubated patient लिखा है, उसके आगे भले लिखा है कि obeys command कर रहा है, open eye कर रहा है, but if patient is intubated, we can consider, हाँ उसका grade 1 या 2 दे देंगे हम इसको. Fine. But that is not the correct answer. We need to know whether the patient is intubated or not. Okay, next is a 70-year-old patient is confused, restless, cannot sustain attention, fails digit span and disoriented, and symptoms started suddenly. What would be the most likely diagnosis? Fine. Whether it is a dementia, whether it is delirium, whether it is depression or amnesia. So the answer is yes, that is grade B, that is delirium. Yes. Why? Because dementia would be having a loss of memory, depression doesn't having all these features always. Amnesia is also having issues with memory, but patient is confused, restless, cannot sustain attention, even fail digit span, and even patient disoriented. And this symptom started suddenly. This is an important word. Fine. So that will be suggesting that patient is in a stage of delirium. Clear? Okay. The next question. A patient can repeat 6 digit forward but only 2 backward. Interpretation is whether it is normal, mild impaired, severe impaired or moderate or memory loss. हमारा digit span में क्या था? 7 forward, 5 backward. ये क्या है? 6 forward, only 2 backward. So that was having a mild impairment. Yes. Fine. So this is having a mild impairment. Normal hota तो there will be 7 forward and 5 backward numbers would be there. Severe होगा तो there will be 3 या 2 जितना ही है. इसमें forward which is 6. So that is considering as patient is having a mild impairment. Next question. A patient is asked to subtract 7 from 100 repeatedly. He gives random answer. Which domain is impaired? Whether it is memory, whether it is intelligence, attention, or language. Yes, that, no, C and B. The correct answer is C, that is attention. Fine. Intelligence, random answers होते हैं, तो that is not suggesting कि intelligence कम है. Fine. Memory, he can easily able to recall, he can do subtraction. Language issues is also not there, so the answer is attention. Think about the questions whenever you are learning. Fine. A question next is, a 60-year-old diabetic patient present with gait disturbances, muscle wasting, shiny skin, pitting edema, and reduced recent memory. Which sections of the assessment are mostly relevant? Fine. So whether it is observation, palpation, memory, GCS, attention and perception, cognition, perception and attention, or orientation, intelligence and insight. So what could be the proper answer? Which are the assessment portions which is most important in this case? Answer A, yes, because patient is diabetic, patient is having gait disturbances, patient is having wasting. So ये सब हो गया observation, edema आ गया palpation में, fine, और reduce recent memory आ गया memory में. So observation, palpation, memory. So the correct option is A. Nice. Next question. A patient with hepatic failure is drowsy, inattentive, disoriented, open eyes to the speech, obeys command, speak confused words, calculate GCS. Fine. So eyes to the speech is having 3, obeys command is 6, and speak confused word, that is 4. क्योंकि 4 था confused, 5 था verbal में normal response. 5, so that is 3, 6 and 4. These are your option, that is 11, 12, 13 and 14. You can count 3, 4, 7 plus 6, that is 13. So your correct answer is 12, sorry. Yes, that is B. Next is, a patient understands language but cannot express words properly after stroke. So whether that is a receptive aphasia, whether that is expressive, whether it is global, or whether it is dysarthria. Which kind of aphasia it is? So it is patient cannot express words properly, patient can understand. So that is an answer B. That is expressive aphasia patient is having. So I hope everyone is clear till now about all these things. We had talked about more of the all our higher mental functions. We had talked about all the major things of the higher mental functions. Yes, for books you can refer Sullivan, you can refer D. John's book of physiotherapy. In that all the neurological assessment is given very nicely. So that has been a good book to refer for the assessment. So I hope you are clear with this. In next lecture we are going to cover about the cranial nerves. Fine. So we are going to detail in a cranial nerve assessment along with the question as we had done for the GCS attention and all the history and on observation portions and demographic data. I hope everyone is clear for this. So thank you for the today. I like that you had enjoyed and you were interacting. That was a good feedback that I was getting. So thank you everyone, and we'll meet in the next lecture with this PFD, and there are other things that we are going to cover gradually in this. Just a second, one more question. Stages of consciousness के बाद GCS ले? No, for stages of consciousness we need to take GCS. Okay, there is a stages of consciousness में एक stages होते हैं, that is RLS stages of consciousness. Fine. This RLS stages of consciousness is having, or also we can consider that as a vegetative stage. Fine, these are the different 8 vegetative states are there. In that we can mention whether patient is conscious, whether patient is alert, whether patient is alert but on command, or patient is having difficulty in memory, difficulty in calculation. So with the help of these stages, like when we go to the patient, we can get to know whether patient is alert, drowsy or that. And with the help of GCS also we can get to know whether patient is able to respond, whether patient is confused. So अगर हमारा GCS आता है कि patient is giving confused answer, fine. So we can get to know that whether might be patient is in obtunded stage, कि patient जग रहा है painful stimulus or responses पे, but patient giving a confused answer, fine. If हमें बहुत बार painful stimulus देना पड़ता है, and only patient will be responding to that, so we can consider that patient is in stupor or semi-conscious stage. If patient is in a drowsy stage, कि patient जग रहा है, patient is responding well, जब आता है for example verbal response अपना आया 5, motor response अपना आया 6, आई ओपनिंग अपना आया 3, कि अगर वर्बल पे पेशेंट्स ने आईज ओपन कर दी, फाइन. सो दैट वी कैन कंसिडर कि पेशेंट इज इन ड्राउजी स्टेज, पर उसके अदर सारे कमांड्स और वो सब दैट इज प्रॉपर, फाइन. सो फॉर दैट वी कैन गेट टू नो अबाउट ऑल दिस थिंग्स. So according to this we can know the stage of consciousness, and also we can get to know about the GCS of the patient as well. Clear with this? Sullivan is not for all the topics of PFD. Yes, majority of the chapters are there. But for PFD, if I talk about neuro portion, there are some chapters which has been given in Sullivan. Other, if you want to go for ortho, cardio, there are different books. If you want to go for a cardio assessment examination, you can refer prior. Okay. If you want to go for ortho, so for different things, there are different books are there. You can refer Kishner, you can refer Norkins, you can refer Kendall, that is for MMT, that is for your, one is for your range of motion. So for different topic, definitely you will be having a different books are also there. Whenever I'll be covering this particular topics, even I'll tell you the reference book, so you can get materials from that as well, fine. For more such sessions also, you can join the batches, join the alpha batch, and you can get to know about the materials also, you can get to know about the different lectures also. So this is all about, for higher mental functions, you can refer Sullivan, you can refer D. Jones physiotherapy book, neurological examination book, in which it has been given properly. Thank you. Any questions? वो सारी details आपको, there is a helpline number which is given. You can contact to that number and you can ask about that, whether you will be getting materials before, prior, after. That all the queries, whatever you has been about those alpha batch lecture, you can contact on that helpline number and you can get it. Yes, Glady is also book, but that is, I'm not commenting on specific book, but you need to choose which particular content you want, and specific content will be given to the proper authorized book. Fine. Any other things? Okay. So for now, today I'll be ending the session. Thank you so much for your all efforts and interaction that you had done. Thank